Many thanks again. This is webinar number 73. We've started nearly 5 years ago. I think September 2020 was the first webinar. So it's great to have so many people still joining us. And we have a great lineup today. We have all speakers are from Italy. Not all of them are Italian, but all from Italy. So we have Marcia Sargarello, we have Marco Bernini, you have Barbara Taglia, and we have Michael Sorotos. You have to guess who's the one that's not Italian from the names. And we have Arun Chakravorty. Arun has not joined yet. I will find him uh, on the attendees because we had spoken earlier today. I'm sure he'll be online. And we have the lovely Cicero Urban has been with us a few times in the past from Brazil. And we have Ricardo Pardo, and he's running the Spanish channel. And thank you for Ricardo for all the commitment. He has been with us since 2021. And we have the lovely Tatiana that has been with us also for nearly a year now. And we have a Russian channel. So if you want to listen to things in Spanish, you go on the Spanish channel. If you want to listen to things in Russian, you go on the Russian channel. You'll find that there is a Chinese channel. So Akram Girgis is the one of the surgeons now also that works with Ricardo, and he's going to try to translate to Arabic. So it's not Chinese, the Chinese channel. If you want to listen to anything in Chinese, it will not work with you today. It will be in Arabic. So if you want to listen to things in Arabic, go on that channel. Please, if you have any questions, put them on the question and answer section so that we can find the questions. You can see already we have 300 plus people online from all different parts of the world, and it's great to have so many of you online. But if you want any questions, please put it on the Q&A section. The chat is mainly for the chat function. Have the chat with friends and colleagues. And now let's start with the talks. So the first speaker is a dear friend. We met on a course in Saudi Arabia, and it has been a real pleasure to know Marco Bernini. And Marco is going to talk about pre-pectoral versus sub-pectoral, and he's going to talk about a couple of other things in implant-based reconstruction. So Marco, the next 15 minutes are all yours.
Thank you. So I guess you are seeing my screen now.
Perfect.
Okay, thank you. So I'm very glad to be here today and thank Yazan for the kind invitation. So my topic today will be the dispute between pre-pec versus sub-pec implant-based breast reconstruction, which is very actual, an hot topic today. Sorry. I think I have a problem with that.
No, sometimes you just need to click on it again and it will work. So it will work okay. What you try, Marco, is go down on the left-hand side, and sometimes the arrow will appear there on the Mac, and then you can start it again.
Okay.
Yes, put the arrow on the right side. Yes.
Okay. Yeah. Okay.
And now try to use the arrows on your.
All right.
Still
okay.
See?
Perfect. Thank you, Yazan, for the advice. So I will talk to you about the state of the art of implant-based breast reconstruction nowadays. And then afterwards, I would like to share with you my thoughts, my ideas, and some ideas from the literature about the indications on pre-pec breast reconstruction, and also about sub-pec, when and how to use this approach. Well, first of all, I would like to start with the idea that all the pre-pectoral approach we are using today actually started at the beginning of this century, at the beginning of the 21st century, with the introduction of the meshes, either synthetic or biological. This new development in the scenario of breast reconstruction actually changed all the things. Because if we look at the trend during the time, we all know that during the 80s and the 90s, the reconstructions were all subpectoral. But at the beginning of this century, thanks to the introduction of the meshes, we were able to shift towards a different kind of reconstruction, which was a hybrid reconstruction, dual plane reconstruction with the muscle on the upper pole and the mesh on the lower pole, which was used to enlarge the pocket, which was still and is still today, namely a subpectoral reconstruction, but a dual plane by means of mesh. Then, starting the first series, starting with the year 2012, we have seen the introduction of a complete pre-pectoral reconstruction, avoiding the use of the muscle and using the meshes as a complete coverage of the implant. Nowadays, we all know, and Barbara will talk later about that, and Marcy as well, that sometimes we have a pre-pectoral reconstruction also without meshes. But at the beginning of this era, the pre-pectoral reconstruction was done with meshes. And to be honest, the first two papers on pre-pectoral reconstruction were Italians, and one was with synthetic mesh, and I was part of that experience. And the second one was with a biological mesh. Both were published in the year 2014 with a series of cases starting in the year 2012, in both cases. And today, the pre-pec reconstruction has really boomed all over the world. We all know that nowadays is the preferred choice all over the world. And if you digit online for example, on the PubMed website, pre-pectoral breast reconstruction, you're going to have 724 results. This is just updated yesterday. And if we look at the time trend of this boom in pre-pec breast reconstruction, not only in the clinical setting, but also in the literature, you can see that the number of publications has really increased in the last few days, except for the couple of days during the COVID era, where all the publications, not only the pre-pectoral breast reconstruction, were decreased. But as you can see, starting from the year 2014, from the very few first papers on pre-pec breast reconstruction, we have been looking at a very increasing number of publications. And if we look at the preferences, nowadays we can answer the question, has pre-pec won over sub-pec? Well, seemingly yes, because if we look at the statistics of the American Society of Plastic Surgeons, for example, about the year 2023, we can see that the number of pre-pectoral reconstruction is more than double the number of subpectoral breast reconstruction. And considering that US were a little bit lagging at the beginning of the pre-pectoral era as compared to Europe, we can say that is definitely the preferred choice nowadays, even in the US, and so all over the world, pre-pectoral reconstruction is now the preferred choice in implant-based breast reconstruction. And so let's go deeper and see when and how is a pre-pectoral breast reconstruction mainly adopted and recommended. So first of all, the first indication, the most important indication for a pre-pectoral reconstruction relies on the breast anatomy. And we all know that there are several classifications and several score to decide whether or not to use a pre-pec approach, but maybe the most famous is the Rancati classification, which divides the breast in three main categories, depending on the thickness of the subcutaneous breast tissue between the skin and the breast gland. And this is maybe the most important thing, as we might know there are several algorithms all over the world. I reported here an Italian algorithm from a group of Italian oncoplastic and reconstructive surgeons, which is very well done, I think, and is mainly indicating the use of pre-pectoral, the use of the pre-pectoral approach, depending on two important factors, all related to the breast anatomy. One, the Rancati classification on, as you can see on one side, type 1, type 2, and type 3. And the second most important factor is the volume and ptosis of the breast. So once again, an anatomic feature to decide whether or not to use a pre-pectoral approach. But in my idea, in my thoughts, and not only in my experience. There are also some other features to be considered when we want to decide if it's prepectoral reconstruction is a good idea or not. This is a paper of mine for the very first era of the prepectoral reconstruction, the very first cases, a series of 146 cases with a very long-term follow-up by the time I published this paper. And anyway, about early complications, I found out that there are some significant statistical factors like smoking, like diabetes, previous radiation therapy, previous surgery, BMI, axillary surgery, adjuvant radiation, and chemo, either in a neoadjuvant or in an adjuvant setting. So all these features must be taken into account when we want to decide whether or not to use a prepectoral breast reconstruction. And that's, as I told you, not only in my experience, but also, for example, in this large series about a prospective multicenter cohort study, the pre-BRA project from the UK, as you can see, the factors influencing the complications of a prepectoral breast approach were not only the breast anatomy, and namely the breast volume with a weight over 600 grams, but also the previous radiation therapy and smoking habit were important factors in order to see complications, to predict complications and implant failure, and so the reconstructive failure. So, in my experience, when we want to decide whether or not to perform a DTI, prepectoral breast reconstruction, we have to choose the right breast with the right anatomy and according to the Rankari classification, but we should also consider some patient characteristics like and features like obesity, smoking, previous radiation therapy, and comorbidities. But in this case, when we are going to fear some complication because of these characteristics or because of not a very good breast anatomy setting, should we avoid a pre-pec approach altogether, or can we find a kind of a compromise to maintain our philosophy and maintain the prepectoral approach? Well, there has been a new approach which came later as compared to the DTI, which is the tissue expander prepectoral approach. The rationale for a tissue expander placed in a prepectoral position is to avoid a compression, an excessive stress force on the vessels, and so to avoid a reduction of the blood flow on the mastectomy flap. Using a tissue expander, we can keep the vessels still completely dilated, not compressed, with a much higher blood flow. And if, again, I reported the GREDA's algorithm, if we look at the GREDA's algorithm advice, you can see that in type 1 breast anatomy, type 1 Rankari breasts, you can sometimes decide to use a two-stage prepectoral approach in order to gain a result which might be ameliorate, for example, with lipofilling in a second section, in a second stage when you are going to exchange the tissue expander with an implant. Or you can choose a prepectoral approach also in type 2 and type 3 breasts when you have a large volume and a severe ptosis, because you are performing, for example, a skin-reducing mastectomy, and in that case, maybe you want to be more cautious, more safe in order to avoid an excessive stress on your scars. And this is my experience. This is a paper published 1 year ago with the very first cases. Right now, I've done more than 120 cases. This is the paper with the first series of 64 cases with a tissue expander placed in a prepectoral position. And so, should we say that prepectoral is always a good choice? Well, still today, sometimes we have to go under the muscle and to choose a sub-pec approach. But if we want to try to see when this is indicated, well, first of all, I have to say that we shouldn't decide to go under the muscle because we want to decrease the complication rate, because the literature now is pretty much coherent, saying that there is no difference in terms of complications between subpectoral and prepectoral in terms of result safety between patients when you choose one approach as compared to the other. So our choice should not be based on the fear of complications, and the decision should be based mainly on the anatomy and the characteristic of the patients you are going to submit to surgery. Because first of all, we all know that a prepectoral approach in type 1 breasts, according to the Rankati classification, is going to give you a rippling anyway, because a skinny patient with a type 1 breast is not a good candidate for a pre-pec, but not for a complication rate, but because of these not pleasant results. And not only a rippling, but also a visible implant rim is another very common complication with a type 1 breast in a skinny patient. So in this case, as you can see, once again, from the Greda's algorithm, I chose this algorithm, but there are many others. This is just an example. In type 1 breasts, they suggest that the sub-pec approach is still the best choice. And sub-pec usually in a two-stage approach in medium and small breast, and a skin-reducing two-stage approach in large and very ptotic breasts. While in type 2 breast, you can try a DTI reconstruction, but still using a sub-pec approach in a dual plane, with a mesh on the lower pole as a good compromise to avoid rippling and visible implant rim. And so, how is the sub-pec approach performed? Mainly, there are two ways, as I told you: a total sub-pec approach, which is mostly done using a tissue expander, or a dual plane sub-pec approach, which is usually done when you decide to go for a DTI, for a direct-to-implant, implant-based breast reconstruction. But what are the main consequences? Well, we all know that the most feared consequence is the breast animation deformity, which is very well known and very disappointing for the surgeon, as both for the surgeon and for the patient. But there's also a worse lower pole definition, because we all know that the muscle tends to draw up the implant, and so the lower pole is not so natural as in a prepectoral approach. So what can we do? How can we perform this sub-pec reconstruction when is needed in order to avoid these drawbacks? Well, I propose in two papers which I published years ago a slight technical modification to try to avoid these drawbacks. Well, this modification is based on the anatomy of the pectoral major muscle anatomy, and is considering that the muscle is made up of three main bundles: the clavicular, the sternal, and the costal bundles with three different nerves. We can actually avoid the contraction of the lower two-thirds of the muscle by selectively denervating the lower two-thirds of the muscle, just cutting the nerves that are going to the sternal and clavicular bundles. And we can easily identify these nerves. For example, here I'm cutting the inferior pectoralis nerve, and here I'm cutting the middle pectoralis nerve, which is very easily found out in the thoracoacromial, close to the thoracoacromial vessels. Whenever you perform a subpectoral pocket dissection, you're gonna, if you go a little bit upwards, you're gonna find quite easily these nerves, and all the maneuver just takes 10 more minutes, and not a big deal. This way, you're gonna achieve good results. For example, in this skinny woman with a type 1 breast, according to Rankati classification, you can perform a DTI dual plane breast reconstruction, avoiding those rippling and visible rims using the muscle on the upper pole. And as in this video, once again, a DTI dual plane reconstruction. When you perform the maneuver for the contraction of the pectoralis major muscle, as you can see, you're gonna see the contraction only of one bundle, the clavicular bundle, which is upwards, which is over the implant. And so you don't need to denervate those bundles, but you're gonna see that all the lower parts of the muscle is completely paralyzed. It's not moving, no more animation deformity. Once again, this is a case of a two-stage sub-pec implant-based breast reconstruction. And this is a video from after the second stage, in the very first days after the second stage, when I removed the tissue expander and placed an implant. And with the muscle denervated, as you can see from the video, when you perform the contraction maneuver, you see only the contraction in the clavicular bundle. Those other bundles, the sternal and costal bundles, are paralyzed, and so you don't see any animation deformity, any visible implant rim, or any other possible movement. So to conclude, sometimes to use or not to use the muscle, as I reported here in my editorial commentary a few years ago on a paper, is a real dilemma, and is not easy to decide. But if we try to decide according to algorithm and to some good advices from different approaches and different techniques, we can achieve good results. Thank you very much.